Welcome back to Skinfluence, your one-stop shop for all things skin health and wellness related. I'm your host, Dr. Dustin Portela. I'm a board-certified dermatologist practicing in Boise, Idaho.
And I'm Austin Lee, physician assistant working with Dr. Dustin Portela.
So today we're going to cover something that's near and dear to our hearts, and that is skin cancer. I know we've alluded to it on a lot of episodes and talked about ways to protect your skin, but this is a deep dive into all things skin cancer because skin cancer kills about 10,000 to 12,000 people a year in the United States. And there are more skin cancers diagnosed than all other types of cancer combined.
Yeah. And it'll show up on you very insidiously most of the time. The vast majority of skin cancers we find, our patients will come in and say, I'm worried about this spot over here, not realizing that a foot away, they have a little skin cancer popping up. And so we're going to go into exactly what they look like, what to look for, what are the risk factors if you're at high risk to develop this, and then when to go see us and kind of what we do to treat them.
Yeah, that is a good point. It's not often the spot that patients are concerned about is what we end up biopsying.
Totally.
Sometimes it is, but usually it's not. So when it comes to skin cancer, there's a few different types that we treat. The most common type is basal cell carcinoma.
Totally. Basal cell carcinoma, like you said, it's the most common type that we diagnose, and I believe it's the most common type of cancer worldwide.
Yeah.
And this one is, we separate skin cancers into melanoma and non-melanoma type skin cancers. This is one of the non-melanomas, and it's usually from sunburns. It's from UV exposure. So we see it very commonly on the face, shoulders, arms. We see it on the upper back or the lower back where you've had sunburns growing up.
Yeah, especially guys that ran around with their shirt off.
Totally. And it's not a skin cancer that typically shows up as a dark spot, although there can be pigmented versions of it where it does look like a mole that's changing. But most often it's this little pimply or pearly bump that shows up that's just slowly growing on the skin that we need to take care of.
Yeah. There's types that can look like a scar, types that look like a pimple. Sometimes they'll ulcerate and bleed easily. People often will come in and say, I've had this pimple for 6 months and it won't go away.
Yeah.
And that's a telltale sign. If you've got something on your skin that you think is a pimple and it won't go away, you need to go have that checked.
Totally.
One of the good things about basal cell carcinoma is it almost never metastasizes into the body. It comes from the stem cells in the epidermis. The basal cells, it's the basal layer, and that's where it gets its name. But it grows in a mucin-rich environment, kind of like snot or like a thick liquid. And it has to be in that environment in order for the cells to proliferate. And it's very difficult for that to occur inside the body. And I read a paper, it's been a couple of years, where if a basal cell carcinoma metastasizes, the average length of time that the person had it was 9.5 years.
It's a long time.
So long time. And even then, I've taken off basal cell carcinomas from people who they legitimately told me, I think that's been there 20 years.
Yeah.
And it didn't metastasize. So they're very unique types of basal cell carcinoma that have to be there a long time before they spread. But what can happen is they don't metastasize, but they can start to grow around important nerves and start to grow backwards in nerves. And this same thing can happen with squamous cell, which we'll talk about. But when you get what's called perineural invasion, they're much more difficult to treat, and you're more likely to lose function or sensation in the skin because we have to take out those nerves that are infected by the cancer.
Yeah. So very treatable.
Very treatable, especially if caught early.
Yeah. So a lot of my patients, when we come in, they have the diagnosis of basal cell carcinoma, and some of them are distraught because we're using the C word, cancer. And a common thing that we say is, if you're going to pick a skin cancer, this is a good one to pick.
Right.
And because it's usually very treatable with either a simple cutaneous excision in the office, or we do a procedure called Mohs surgery.
Yeah. And sometimes when they're only growing in the top layer of skin, it's called a superficial basal cell carcinoma. If that happens on the trunk, like on your back, we'll do a procedure called an electrodesiccation and curettage, where we use a curette to scrape out the top layer of skin cells and we cauterize the skin. And that has a cure rate of about 80 to 85%.
Yeah.
And it's not 100%. Nothing in medicine is 100%. Mohs surgery is like a 99% cure rate. Excisions are 95 to 99%. And so it's one of those things where you can save a lot of money by doing an ED&C, but the cosmetic result isn't always ideal, but it's less downtime. It's less restrictions on your activity. You can get back to doing the things that you love. You can usually still go swimming and things if you've had an ED&C. If it occurs on the face, the neck, the backs of the hands, over the shins, in the groin, that's really where Mohs surgery is the gold standard, because it allows for less normal tissue to be taken out. We don't need to go into all the depths of Mohs surgery, but basal cell carcinoma is that first and most common type of cancer that we see more than anything.
Yeah. Almost on a daily basis, I would say. We're doing a biopsy of one that we suspect or doing a surgery on one that we found.
Yeah.
Very, very common. Another type of skin cancer that we see very commonly in the office is called squamous cell carcinoma, which also is from UV exposure over time. We see it in sun-exposed areas, just like in basal cell carcinoma. This one more commonly kind of on the tops of the ears, or we see it on the arms. It does have a precancerous phase called actinic keratosis, which are these little really rough, sandpapery, reddish spots we see on the skin. We'll tend to freeze those away. But squamous cell carcinoma, very much like basal cell carcinoma, we see those, we biopsy them, they're treated with Mohs or with a cutaneous excision. I was always taught to have a healthy respect for squamous cell carcinoma because it can metastasize, especially in certain areas like the lips, the ears, the nose. But
there's certain features of a squamous cell that can make it more high risk. On average, if you take all squamous cell carcinomas, it's like 2% metastasize. But if you get one that grows on the lower lip, on the tops of the ears, larger ones on the scalp, they have up to a 20% risk of metastasis. And now we have a genetic test that we can run on a biopsy sample that gives us a better idea if something's going to metastasize. And they categorize that as low, intermediate, or high risk for metastasis. And recently our surgeon, Dr. Farrell, had one that was that was a large one on the chest of an individual, and she got it all out with the excision, but the genetic test came back as a high risk for metastasis.
Oh, wow.
And sent the individual in for a CT scan, and it had metastasized to lymph nodes in the armpit.
Oh, wow.
And so that is something that 15 years ago that we would have cut it out, and then 6 to 12 months later, the person would have had a large lymph node growing. Maybe it had then gone to the lungs. But now with this genetic test from Castle Biosciences, no conflict of interest there, this test allowed that person to get a diagnosis earlier so that those lymph nodes can be removed. They might be getting immunotherapy or chemotherapy, and it significantly improves their prognosis.
Yeah, it's been a great tool.
The squamous cell carcinoma still comes from skin cells, but they're a little bit more mature. So they're not at that basal layer. It happens as the cells have started to keratinize, and a keratinocyte can survive in a lot more environments. It doesn't have to have that mucinous stroma, which makes them higher risk for metastasis. And you can get squamous cell carcinoma that starts in the mouth, in the esophagus, in the lungs. And so squamous cells are elsewhere on the body, and they have a lot higher risk of metastasis depending on where they start, their size, their ulceration, things like that.
But again, very common that we see that in the office, and the vast, vast majority that we see are excised or through Mohs or excision and are very treatable.
Yeah.
But when you start to develop these types of cancers, we see you very frequently in the office because when you have one, the sun didn't hit you just in that one spot. We have to keep an eye on you and make sure, and we see you more frequently. But those are the non-melanoma type skin cancers. And then there's melanoma.
Yeah. Melanoma, there's almost 100,000 a year that are diagnosed. Thankfully, most of those are going to be melanoma in situ. This comes from the melanocyte of the epidermis, the pigment-producing cell. It produces pigment to help protect us against ultraviolet light and transfers that pigment into the keratinocytes, and that's what makes us tan. But the melanocytes come from embryonic development, where we get melanocytes in the skin, but also in the gut, in the brain, in the eye. And so melanoma can develop in almost any tissue of the body.
Right.
And because it can develop in almost any tissue of the body, it also can spread to almost any tissue of the body. So when you have melanoma in situ, it's just in the top layer of skin. And the standard treatment for that is an excision with wide margins to make sure that we get it all out. But if you have a melanoma in situ, the 5-year survival rate is approaching 99%.
Right.
And just cutting them out. You don't need chemotherapy. You don't need radiation. You do need regular skin checks. But melanoma in situ is the most favorable type of melanoma to have.
Right. And fortunately, we have the Castle Biosciences test. When we do those, if they're past the in situ, the superficial phase, we can do that test to see if it has high risk for metastasis.
Yeah. So once a melanoma, most of them will start in situ, and then they'll enter what's called the vertical growth phase. So instead of just growing wider on the skin, they start to grow up and down. And when they break through the epidermis, this is called invasive melanoma, and the risk for metastasis goes up significantly once you have an invasive melanoma. And it's interesting to talk to patients about this when we have to have these conversations, is that if your melanoma is over 0.8 millimeters deep, then you need a workup for systemic metastasis. You need a CAT scan. You need a consult with a surgical oncologist. You need to have lymph nodes biopsied. And if you can think, like on a ruler, how big 1 millimeter is, it's only 0.8 of 1 millimeter.
Yeah.
And that tells you how aggressive melanoma can be.
Yeah. There's something that we look out for when we're looking for melanomas, because there's very often the patient comes in and they're worried about this dark mole over here, and we go, have you seen this one? Oh yeah, this one's been changing.
Yeah.
So typically things that we're looking for when patients are coming in and we're doing skin checks, we talked about kind of the basal cells look like a pimply bump or an ulcerated or easily bleeding bump. Squamous cells can look similar to that, but they usually start as like a flaky spot. But melanomas will start as it'll usually be like a mole that's slowly changing over time. You had mentioned that they'll spread out superficially on the skin most often before they start to go deep. When they start to go deep, they'll develop sometimes a little nodular component. They'll start to protrude out of the skin. But if you notice a mole that you have or a new mole that breaks certain rules that we call the ABCDEs of melanoma, A stands for asymmetry. So if the one half is unlike the other half, we need to evaluate it. It makes our ears perk up a little bit. The B used to be bump. And they must have done a great job at talking about bumps, because very often in the office, every bumpy mole, people get concerned about.
Yeah.
But B actually stands for border. If the border looks like a fluffy cloud or has a irregularly shaped border where it fades off into the skin on one side, it's very distinct on the other side. If it's not a normal border throughout, that is something that we look for. C stands for color. So if the color varies within the mole, if you have a light spot or a dark spot, or there's different variations of brown and black inside of that mole, we look at it. Very often people will come in and say, this mole's darker than my other mole. And that could be okay.
Yeah.
It's variation within the same mole. D stands for diameter. I've seen melanomas bigger and smaller than 6 millimeters, a pencil eraser.
Yeah, I think the diameter is not the strongest indicator.
Yeah.
But if you do have a invasive melanoma, they often are getting bigger.
True. And then E stands for evolving. Any changing in moles that are especially rapid changes. Now, it's not usually over weeks that you're noticing things, but very slowly over months, you may notice changes in these moles.
Yeah, I think change or evolution of a mole is your strongest indicator when you're doing self-skin checks. If you have a mole that's looked one way for years and all of a sudden, over a 6-month period, it definitely looks different, that kind of change should be evaluated by a dermatologist.
Totally.
Only about 30% of melanomas come from an existing mole. So you've had a mole your whole life, and now it changes, it's become a melanoma. That only happens about 30% of the time. 70% of melanomas are what we call de novo, meaning it's a new brown spot that grows. If you're over the age of 35 and you're starting to get a new mole, that should be investigated by a dermatologist. It may warrant a biopsy, because you shouldn't really be growing a lot of new moles after the age of 30 to 35.
Right.
A couple other things that I tell patients is to look for the ugly duckling. And this is what I do on skin exams. If all of your moles are like pitch black, but one mole is like a grayish brown, that's the one that's going to concern me more, because it's different than what your body normally makes. If all your moles are brown and you have one that's black, I'm going to key in on the black one.
Yep.
And it's more likely to be harmful, because melanoma that starts developing is not going to behave like all of your other moles. And the thing that keeps dermatologists awake at night more than anything else is what's called an amelanotic melanoma.
Oh, yeah.
Amelanotic meaning it doesn't have color. It's a pink or flesh-colored bump. Sometimes when we look close with our dermatoscope, we can see the leftover remnants of a little bit of pigment, but sometimes they can be straight up pink. And previously on the podcast, we had Dr. Michael Christopher, who is a dermoscopy expert, and he has this phrase, which I've heard elsewhere too. If it's pink, stop and think.
Totally.
So if you're growing a new pink bump somewhere on the body, again, just new things, have it checked out by a dermatologist.
Totally. I've had a case years ago where a lady, now melanoma, like we were discussing, it doesn't just show up on the skin. That can show up in the nails.
Yeah.
You can get these dark streaks, irregularly shaped streaks on the nails. Usually if you have a perfectly vertical line going down the nail, it's okay. But if it's new, have it evaluated. But this lady it started as a dark streak in her nail and then turned into kind of this pinkish bump at the cuticle area.
Yeah.
And it was treated as a fungus for months.
Yeah.
And when she finally came in, it was this very obvious pink bleeding bump.
Yeah.
And she lost her toe over it because it was melanoma growing out of the nail.
A very similar situation. Residency guy had been treated for fungus on his thumb for about 3 years.
Oh.
It had eroded away most of his nail, and we did a biopsy, and it was an aggressive melanoma. It was 4 millimeters deep, I think. And he was referred to a surgical oncologist. He lost his thumb.
Yep.
The lymph nodes were negative, and he was so mad at me that he lost his thumb.
Oh.
I'm like, dude, you had a melanoma for years.
Yeah.
He was just, nice guy, but he was not a happy camper most of the time in life. But I was privileged to take care of him, and it is one of those things. The challenging thing with melanoma is we talk all the time about sunscreen as the best way to decrease your risk of skin cancer. And we have the most data on sunscreen for prevention or reduction of risk for basal cell carcinoma and squamous cell carcinoma. But the data is not incredibly strong that it prevents melanoma. Now, certain types, like a superficial spreading melanoma on the face called lentigo maligna, that is definitely sun exposure related, but many melanomas can appear in areas that have not had a significant amount of sun exposure.
Totally.
There's a much stronger genetic component to melanoma when it's compared to basal cell or squamous cell. And so just because you wear sunscreen all the time does not mean you aren't at risk for melanoma. This is where we really like to know a patient's family history. If there's a first-degree relative that's had melanoma, even if you're great about sun protection, you need those full skin exams because if you have a genetic mutation like CDKN2A or several others, your risk of developing melanoma can be much higher than the average person, regardless of your sunscreen use.
I totally agree. One of the first things I'll ask my patients when we're doing skin checks is, do you have a family history of melanoma? And if they do, we'll probably be doing yearly skin checks. And because it is genetic, like you were talking about, it's going to show up where the sun's not shining. So the bottom of the feet, in between the toes, not incredibly common, but it happens. It can even show up on the private areas. I don't typically check the private areas unless there's a reason to that the patient is stating, but I do check rear ends because the lower back, it can show up there.
Yeah, I've definitely taken some off there. So, I mean, melanoma can show up where the sun don't shine. To use the full course of that word, it can happen in the bathing suit area. And I've unfortunately recently lost a patient who came in with about a 2-centimeter melanoma that was on her backside, and just learned that she passed away this last year.
Oh, I'm sorry. So, that's always hard.
Yeah.
Well, early detection is always key. So if you find yourself in that category where you have a first degree relative, and I even extend it out, if your grandparents or even like your mom's aunt and uncle had it, just get checked regularly. You had mentioned the ugly duckling rule. I have so many patients who come in and they are just covered in moles. And I recommend that they watch themselves and they go, I don't even know what to look for. And I say, look for the ugly duckling. Like, look which one doesn't fit in with the rest. And then if you notice anything changing, come in.
And that is where a relationship with a dermatology provider is very important, because we know that it's hard to check your moles. You should put forth the effort. to get in your birthday suit once a month, grab a mirror, look at your backside, look at everything. But we're here to help.
Yep.
We photograph things in the clinic. We look at things closely. I take dermoscopy photos, and that really helps us to have early detection, because in a majority of cases, even with melanoma, early detection saves lives.
Yeah.
If we can catch it early before it has started to invade, the chances of survival for a melanoma in situ, like I said, are approaching 99%.
Yeah.
And so it's critically important to be checked out. If you're 30 to 40 years old and you've never had a skin check, it's a great time to go get that first skin check.
Yeah.
And just make sure everything's okay, and then find out how often you need to come in based on your personal risk.
Right. And sometimes people come in, or they don't come in because they're scared that we're going to do a biopsy. And a biopsy, it's incredibly simple these days. It takes 2 minutes to do. There's no stitches involved. It's very superficial. There's no lifestyle restrictions afterwards besides a Vaseline and a Band-Aid.
Yeah.
And what I tell most of my patients is it's better to be safe than sorry.
Yeah.
And it's such a simple thing to do. It's very small typically. So
Yeah.
I've had biopsies done on myself, and I hate needles, and it wasn't as bad as I thought it was going to be.
I've done my own biopsies on myself sometimes when I'm worried about things. So it definitely is a fairly straightforward procedure. We're always concerned about the cosmetic result. If it's on the face or anything like that, we take great care to make sure that everything is good. But if there's a cancer, that's going to do more damage to you than any biopsy will.
Yep.
And part of that genetic component that we talked about is not just risk of melanoma. If your grandparents have had basal cell or squamous cell, you probably inherited fair skin from them. If you're redhead, you've got a higher risk because you don't make the same kind of melanin. So all of those things are important to be aware of.
Totally. Well, let's move into a Did You Know?
All right. What do you got for me this week, Austin?
Well, I have a sad statistic about melanoma.
Okay.
But in the United States, about one person dies every hour from melanoma.
Yeah. That is a sad statistic. It's close to 8,000 to 10,000 people a year.
Yeah.
Yeah.
So that's why getting in early saves lives.
Yeah, absolutely. My Did You Know is a personal clinical experience. If you had to guess the youngest person I've ever diagnosed skin cancer on, what would you guess?
Oh. I'm going to guess 12 or 13.
Close. I'll give you melanoma. The youngest I've ever found a melanoma was 17.
Was 17.
Yeah. But the youngest I found a basal cell carcinoma was about 1 year old.
1 year.
Yeah.
Oh, did they have basal cell nevoid syndrome?
So there is something called basal cell nevus syndrome or Gorlins syndrome, where they have a mutation in the coolest named gene ever called Sonic Hedgehog. So this gene is literally called Sonic Hedgehog. And if you have a mutation in this, it's an autosomal dominant condition. So if one of your parents has it, your risk of getting it is 50%. And you are at high risk of developing basal cell carcinoma. And it's essential to stay out of the sun, because if you go in the sun, you're going to develop basal cell at a much higher rate. But these basal cells, especially in children, don't look like your typical basal cell. They can often look like a skin tag.
Or an IDN.
Yep.
Intradermal nevus.
And so this child was right around 1 year old. It was at the pediatric dermatology clinic, and they had 4 or 5 of these little basal cell carcinomas. And
so bad.
you just feel awful because there's currently no gene therapy or anything to treat this. The child has to have diligent sun protection. And when they're like that, you can numb them up and scrape them off. Usually we're not doing full excisions and everything. But I have a number of patients that I treat in the clinic with basal cell nevus syndrome, and the treatment options have improved. There's systemic chemotherapy agents that we use in dermatology, but they have their own toxicities and risks, and they're hard medicines to be on, but they do save lives.
Yeah.
So 1 year old.
1 year old. That's wild.
Yeah.
I've had a patient with that, but they were teenagers by then.
So, well, that's your Did You Know. Let's get into the most important thing we're going to talk about today, prevention and early detection.
What would you recommend for patients to look for or do to prevent or detect skin cancers then?
It should come as no surprise, but you need to be wearing sunscreen every day.
Big surprise.
Big surprise. So every day before I leave the house, I put sunscreen on my face, my head, my ears, the back of my neck. Those are always covered. It's non-negotiable for me. I've tried tons of different sunscreens. There's so many that are cosmetically elegant. I think nowadays there's no excuse to not be able to find a sunscreen that works well with your skin.
I agree.
That feels good, that you like to use.
Yeah. All skin tones can wear sunscreen. It'll blend well. I hate the smell. Growing up, I used to hate the smell of sunscreen and the way it made my skin feel. Now, there's so many you put on, you can't even feel it on your skin. It's just, it's not there, but it's protecting you.
Yeah. And sun protective clothing, that's another way to help protect yourself. UPF shirts, they're more fashionable. They're easier to wear. They feel better. They dry quickly. All of those things. So daily sun protection, whether it's sunscreen, wide-brimmed hats, or sun protective clothing, I think it's really easy. It's easier than it's ever been to take protective measures.
Totally. Something that I will recommend to patients who I feel like are a little bit higher risk, and we're doing skin checks regularly, but is to examine themselves frequently. So we have this beautiful thing called a phone that takes pictures.
Right.
And pictures are the best way to document. You can create a little folder on your phone. If you have lots of moles, or if you have a mole you're concerned about, take a picture and then come back a month later, take another picture, and just compare. If there's changes that are drastic, come on in and we'll take a look.
Yeah.
Moles will get darker. They get darker in the summertime. They get lighter, but the borders, the ABCDEs that we talked about, should not be changing.
Yeah. You can password protect that folder on your phone so nobody else is going to see it. But it's important, if you need help, get a family member to take the photo of your back. Hold the phone the same distance away from the skin. Do it in the bathroom or the same room of the house so the lighting is the same. And try to make it as close to the same photo as possible so that when you swipe through that album, you can see if there's really a difference. And do not check more than once a month.
Yes.
Because if you check daily, you're never going to notice change. It's going to always look the same to you because it doesn't change overnight. But if you're checking once a month and something happens, you will likely notice that difference.
I totally agree with that. So if you are high risk, and what would you define as a high risk person for any type of these skin cancers?
So when you've had skin cancer yourself, that's the biggest risk because your chances of getting another skin cancer are higher than anybody else. If you have a first degree family relative, that means mother, father, son or daughter, brother, sister, then you need to be getting regular skin checks. If a first degree family member has had melanoma, if a second degree family member, like a grandparent, an aunt, or an uncle, if they've had melanoma, it's good, I think, to go get a baseline, but that doesn't necessarily mean if you're a teenager that you're starting annual skin checks.
Totally.
If you're a redhead, you're very fair-skinned, that's a good time to get a baseline skin exam and then have a good relationship with the dermatologist and determine how often do I really need to come in. So,
if you're concerned at all, just go see a dermatologist. We'll do a baseline check. If we feel like you're low risk, we'll see as needed. But if we can give peace of mind, that's part of our job as dermatology providers.
Absolutely.
We talked about sunscreen myths busted.
I think we did a whole episode on that, but we can touch on them lightly.
What myths are we?
Oh, like sunscreens cause cancer.
Oh, gotcha.
Toxic endocrine disruptors, whatever.
It's like, wait. So we've touched on sunscreen quite a bit and its importance. There's always the myth that's going to say the sunscreen is what's causing these skin cancers, but it's not true.
It's definitely not true. Correlation does not equal causation. Any basic statistics class is going to teach you that. And yes, sunscreen usage rates have increased, but skin cancer rates have also increased. But there's many confounding factors and many reasons for that. But great data, particularly out of Australia, has shown that frequent sunscreen use, especially starting in your youth, decreases the risk of skin cancer in the future, particularly basal cell and squamous cell carcinoma. But there is a signal that it also reduces the risk of certain types of melanoma. Sunscreen is not an endocrine disruptor. No evidence to suggest that in humans. Sunscreen is not toxic. It's not going to cause the cancer. It's not going to disrupt your hormones. So anybody saying these things, they don't know what they're talking about based on the evidence that we have today.
Totally. So wear sunscreen.
Wear dang sunscreen.
One thing that you had mentioned is that melanoma can show up. So we call, when you get your first melanoma, we call it the primary site.
Yeah.
And then if it metastasizes, those are secondary sites. One of the primary sites can actually be your retina. You had mentioned it could be elsewhere in the body. So one of the things that we do recommend, if you're going to be, especially out on water or things like that, where you're just going to be in direct sunlight, is wearing sunglasses, because that protects our eyes from UV damage. But if you are at risk for melanoma, if you have one of the genes that put you at a little bit higher risk, sunglasses will protect you from getting. I've had patients who've had melanoma as a primary site on their retinas, and that's a scary thing because you can't see it.
You can't see it. Yeah. Jimmy Carter, his melanoma started in the eye.
Really?
Yeah.
Yeah.
So it's important to know. So there's certain genetic mutations. That's why if you have a first degree family relative that's had a melanoma, not only should you be getting skin checks, but you should be getting a dilated eye exam where the eye doctor can look at the retina, because those can be seen and they're better at treating them than ever before. It used to be if you had a melanoma in the eye, you lost the eye. They just cut the eye out. And now they can do targeted radiation therapy and other things that save your vision in that eye. You may have some impact depending on how close it is to the fovea. But I've had patients who had ocular melanoma, whether it's on the sclera or on the retina, and their vision is still excellent.
That's amazing.
So it is something to be aware of. And those genetic mutations, some of them you will not catch. And that's the thing that frustrates me about melanoma, is that it can show up in areas. There was a nurse at a dermatology office that I worked at in residency whose primary melanoma developed in the rectum.
No kidding.
And even if you're checking every nook and cranny on a skin exam, you're never going to see that.
Yep.
And so I don't recall how old she was, if she was a candidate yet for getting annual colonoscopies, but unfortunately she succumbed to it. And that's the bad thing, is that we can't prevent everything, but the majority of melanomas that develop on the skin can be caught early and treated successfully.
Yes.
So that's important to know.
Yeah, that's a sad story, but go see your dermatologist if you have any questions. If you're concerned at all, or if you're at high risk, come in and we'll take a look at you, and we'll go over everything that you need to be looking for and aware of in terms of melanoma, in terms of other types of skin cancers. There are other types of skin cancers that are less common than those, but the vast, vast, vast majority of our time is spent finding and treating the ones that we discussed today.
Yeah, basal cell, squamous cell, and melanoma. Merkel cell, Jimmy Buffett died of that.
Jimmy Buffett, yeah.
And that often occurs in sun-exposed areas if you're going to get it.
And it looks like a basal cell very often.
Yep, can look like a basal cell. Every time I've biopsied one, I've always thought, this is a really bad basal or it's a Merkel.
Yeah.
And they're more lethal than melanoma.
Yeah, they're very, very aggressive.
So very challenging to treat. So we don't mean to be a downer.
I know.
Talking about
a heavy
cancer
episode.
A little bit, but
that's an important episode.
We want to give you some optimism that we're your partners in this. We're here to help catch them early, treat them successfully with the most advanced treatment techniques. When it's appropriate, we bring in a care team of surgical oncologists, medical oncologists, radiation oncologists to make sure that it's being properly addressed. And I have 2 patients right now who have metastatic melanoma who are going through immunotherapy and seeing incredible results. So hats off to our research colleagues, our medical oncologists. The advances that they have made in immunotherapy for melanoma have been life-changing, life-saving, groundbreaking, and we're grateful to be a part of the care team for somebody suffering from melanoma.
Yeah.
So that being said, we do want to leave you guys with a product of the week. We have talked about the Neutrogena Collagen Bank line before. Collagen Bank is a line of facial products. They have a vitamin C, they have a sunscreen, they have a moisturizer. And these products not only help to preserve the collagen in your skin using micropeptides or nanopeptides that help to signal your body to make more collagen, but they do make a collagen bank SPF. So not only are you helping your body to build more collagen, because we're all concerned about fine lines and wrinkles, but you're getting the minimum requirement of SPF 30 on the skin that's going to help protect you from basal cell, squamous cell, and even some melanomas. So Neutrogena Collagen Bank, we're going to have a link to that down in the podcast show notes, or in the YouTube video description. And if you've tried this from other episodes we've talked about it, send us some feedback on Instagram. Skinfluence_pod is the handle. We'd love to know how you're enjoying any of the products that we've recommended.
Yeah. I'm sure no one is surprised that today's product of the week is sunscreen.
It was kind of obligatory.
Yeah. We had to do it.
So we could have talked about, Soul Defense gummies, Polypodium leucotomas. There's lots of things that we've talked about on previous episodes that can be in your sun protection regimen. Maybe we need to launch our own Skinfluence UPF clothing line, something like that.
Kind of cool, actually.
Big floppy hats. I don't know, something like that.
Yeah. Sunglasses.
Anyway, thank you for joining us. I'm Dr. Dustin. You can find me on all social media platforms at Dr. Dustin Portela.
You can find me on most social media platforms, the most popular ones, at Austin Lee PAC.
Guys, thank you for joining us on this episode. Leave us a 5-star review wherever you listen to podcasts at. Share this episode with a friend, and we'll catch you on the next episode.